Now we have covered the elements water and air. We are entering fire. Redness in neonates, a pediatric Ophthal perspective by Dr. Soumya Nambiar, who is the pediatric consultant at Comtrust Eye Hospital.
So, good evening one and all. So, how many of you are general ophthalmologists here? Yeah. So, there is always a tension whenever an infant comes to you. The parents have multiple questions to ask, and we are faced with a problem like what we have to see the child, what do we do with the child, where do we send the child. So that's the initial fear that comes to everybody as a general ophthalmologist, where we have to send the patient. Okay. So basically I'm dealing with the redness in these children. So most often what we see is redness in these children. So the objective of my presentation is to describe the common and varying presentations of such children. Basically, I'm dealing with infants. Describe what is the importance of history taking in these children, and to emphasize the importance of timely reference, and to emphasize the importance of general examination. So these are the things that we can do as a general ophthalmologist. So let's see this with each case. So a 6-month-old baby comes to me with watering of eyes and discharge since 2 weeks. So what do I ask? I ask, is the child rubbing the eyes? Is the child having fever or cold? Any history of trauma? So my questions are directed towards this, and by this at least you will have an idea what the child is having. Okay? So you may not get any history from the child. So from the parents you can get at least these 3 main things. And you find that, okay, the child is having some conjunctival congestion. You can do a torchlight examination definitely, but I would also suggest if you have an indirect ophthalmoscope, you can use a 20D, and then you can have a magnified view of the child, make the child lie supine, have a magnified view of the eye, and at least you have little bit idea where the congestion is, which part of it is congested. Okay? Foreign body is one thing that you should remember. Always try to avert the lid. You will not miss out this very frequently. It's very common. It's not very uncommon. But unless you avert the lid, you will miss this out. So another case is that of a child with redness and swelling in the left eye. So you can see this. The child is having a lid abscess, and you can see that there is a here there's a lid abscess, and secondarily there's a secondary bacterial infection. Because of that there is a preseptal cellitis also developing. But if you can see, there are multiple lesions on the face also. So it's a molluscum actually, and there was a molluscum in the lid which has got secondarily infected and caused this. This is a 3-month-old child. I don't have the picture of the child because a 3-month-old child, and the child came with bilateral severe purulent discharge. Okay, so my first thing on examination, there was definitely a diffuse conjunctival congestion. There was no other anterior segment abnormality, and I took a conjunctival swab from that, and this turned out to be a methicillin resistant staph aureus, and based upon that, and it was sensitive to moxifloxacin. So I started on moxifloxacin, no fever. Luckily the child did not have any fever, so I started on moxifloxacin, and the child responded well to that. So neonates are at a high risk of conjunctivitis due to many predisposing factors. One is because of decreased tear production, because of the lack of IgA in tears, decreased immune function of the child, and absence of lymphoid tissue in the conjunctiva, and decreased lysosomal activity. So this is a case of internal hordeolum. Okay, so this is very common to see, and as we all know, you give hot fermentation, you give systemic antibiotics depending upon the age and the weight of the child, and the topical antibiotics you can start. Now another thing that you should remember, that a child, if it comes with this picture, you can see that there is a subconjunctival hemorrhage. So ask the history if there has been a, this is a 2-month, this was actually a 10-day-old child. So I just asked the history. There was a history of vacuum delivery. So that itself can cause the subconjunctival hemorrhage in such children. And always look for the bleeding parameters. You can always take the help of the pediatrician who is looking after the child, and see if the bleeding parameters have been looked into. Anemia, BTCT, all that, if it is done, platelet count, how is the platelet count, that also has to be ruled out. Along with that, you have to do a dilated examination. Digitally, at least you can check the intraocular pressure in such children. So, I had a child who was referred for redness with this kind of a picture. So you can see that there was no history of trauma, but the child was referred, came to the emergency department telling that there is a foreign body in the cornea. But when I saw, I used the same thing, indirect ophthalmoscope. With that IDO, I just checked, and you can see that there is a small deposit here, if you can see. So this is not on the cornea, it's inside, on the endothelium. So it is a granuloma that is there. So some children can present this kind of picture also. So it's a granulomatous uveitis. We had a systemic workup for this child, and we are waiting for the results. Now a child comes with redness following fever. There is a history of corona in the family. The child had a fever 1 week before this episode. So you can see that there is a diffuse scleritis-like picture. And you can see multiple necrotic areas like this. And this looks like more of a necrotizing scleritis kind of a picture. So with the help of the pediatrician, we started the child on antibiotics, and with the steroids, the eye was quiet. So never to forget this condition. This is the most dreaded condition and very common to see in children. You get all kinds of injuries, a pencil injury, a broom injury, a stick injury, a knife injury. All this can land up in this position. So you have to be wary of this condition as well, the traumatic endophthalmitis. And this child, so as I told, a general physical examination is very mandatory. The child was brought with congestion, and you can see that there is a lid coloboma. There are multiple, there's a preauricular tag, there's a macrosomia, it's a case of a golden heart syndrome. So you can have this kind of syndromic child also coming up to your OP, and you should be wary that all this is possible. So this is because of the exposure, because of the lid coloboma, and that the child had developed redness. So thank you all for the patient hearing.
I think what was key through every presentation is the need for a complete eye exam. Very often, as in our adult patients, the minute you find something significant, the brain switches off and you kind of look at it. I think it's important to go back to our postgraduate days and remember our teachers who insisted on looking at every eye from the eyelid to the retina. And I think every one of the cases, the speakers have reiterated the need to rule out other anomalies. So I don't think this session could have reaffirmed the need for a complete eye exam anymore. The second thing, I think, as pediatric ophthalmologists, that all of us get a little upset and angry at times is we don't see our fellow specialists give importance to refraction and vision rehabilitation. So once they've solved the primary subspecialty issue, often the child is left and are called back for a review after a few years. And many of these children would have an inherent refractive error, which we miss an opportunity at times like this to identify and also rehabilitate. I think that is very, very, very critical. I think what ma'am presented as a part of ROP is, as ophthalmologists, we should not be contented with what we are treating, but try and see, is there something better we can do for our children to minimize or mitigate whatever risks that those children have. And I think the last bit is we've seen nomenclatures change from cortical vision impairment to delayed visual maturation to term to preterm. Essentially, I think we are also understanding a lot of these conditions a lot better. And we also realize that there may be an opportunity for us to stimulate some potential vision in these children. So rather than just branding them as blind, today we do find that vision stimulation at least enhances certain aspects. They may not get the regular visual outcomes that we see in other children, but there is an opportunity for us again to rehabilitate. So giving some hope to the parent ensures that the child are with us and we can subsequently rehabilitate them to try and make them as independent as possible.
I'm sorry to interrupt.